Hello, my name is Melanie Campos and I'm going to talk about the single-dose Oritavancin in the treatment of acute bacterial skin infections. Definition: the economic burden of acute bacterial skin and skin structure infections remains substantial as is driven by the high cost of hospitalization and by treatment with agents that require dosing once or twice daily for a duration of 7 to 10 days or more. Treatment of these infections often requires agents that are active against methicillin-resistant Staphylococcus aureus, which continues to be an important causative pathogen in the main countries. Even treatment in an outpatient setting cannot overcome the disadvantage of multiple administration, incomplete adherence to the medication regimes, and the complexity of the monitoring therapeutic drug levels.
Hello, in this video we're going to talk about cellulitis and erysipelas, which are bacterial skin infections. Cellulitis is a bacterial skin infection of the dermis and the subcutaneous tissue. The normal presentation of cellulitis is an infection in the lower limb, such as near the tibia, for example. A good differential for cellulitis is another bacterial skin infection called erysipelas, which is actually known as superficial cellulitis because it is infection of the superficial dermal layer. So let's just learn about erysipelas first, but first of all recap the anatomy of the skin. The skin anatomy, the skin layers, two main ones, epidermis and the dermis. Below the dermis is your subcutaneous tissue, also known as the hypodermis, which is what actually makes up your superficial fascia. Below the superficial fascia is a deep fascia, a layer of connective tissue which surrounds organs such as your muscle here. Erysipelas is an infection involving this area here, which is the superficial dermis. Again, it is a superficial dermal infection. The main causative agent is usually group A streptococcus, which is also known as strep pyogenes. It is essentially a cocci, a gram-positive cocci. The clinical presentation of erysipelas, classic one, is an example of a patient coming in with sort of a swelling, inflamed, butterfly appearing rash, which is a good differential for systemic lupus erythematosus. Aside from this, the patient can present with systemic features such as fevers, chills, rigors, as well as lymphatic involvement. Erysipelas can also present in the lower limbs, such as around the tibia, for example. And it has the cardinal features of inflammation, which is very important. These are warmth, erythema, which is redness, tenderness, as well as swelling. So
the applications medicine is the Oritavancin is a lipoglycotype antibiotic and three mechanisms of action that results in concentration-dependent bacterial activity against clinically relevant gram-positive pathogens. Oritavancin has prolonged terminal half-life and is increased unchanged in both organs and face. No dose adjustment is required on the basis of age or renal function for patients with moderate hepatic impairment.
Thank you for joining us today for this Contagion Peer Exchange panel discussion. More than 750,000 hospitalizations per year.
Capable of causing an infection, and an infection is harder to treat because the stuff is more resistant.
as he mentioned, IV antibiotics are pretty much the main reason why these patients are being admitted.
Hello, and thank you for joining us today for this Contagion Peer Exchange panel discussion.
The pros and cons. The incidence of adverse events that develop during treatment, regardless of the relationship of the event to the study drug, was similar in the Oritavancin and Vancomycin groups, and most of the events were mild. The most frequently reported adverse events in the Oritavancin group were nausea and 11% versus 8.9% in the Vancomycin group, headache, vomiting, and diarrhea.
So at our institution, we developed a protocol for appropriate use of Oritavancin, and one of those implications in that protocol is using Oritavancin to expedite patients who are admitted inpatient to expedite their discharge. So in this study, we looked at patients who received Oritavancin to expedite their discharge, and we looked at patients who received conventional treatment with vancomycin and oral antibiotics. In terms of cost avoidance, even though we spend a significant amount of money for the medication, which is about $2,700, we save money in the long run because we are reimbursed based on DRG or diagnosis-related group. And for us to receive that, it doesn't matter how many days the patient stays in our hospital, we get the same flat rate. When the cost of the hospital admission is $2,750 a day for a patient to walk through our door and sit in the hospital, not including any labs, tests, or drugs, or nursing time, and we only get reimbursed about $5,400 of that, we want to try to match that as close as we can. In terms of the clinical implications, by using Oritavancin, our patients have less time in the hospital because we're using it to get them out. A lot of times we keep patients inpatient to just give them IV antibiotics because we maybe don't think that they'll take oral antibiotics, or they're have too severe of an infection to take oral antibiotics. So we keep patients in the hospital longer just to give IV antibiotics. But the Oritavancin completely eliminates the need for patient compliance. We give them the once infusion, and the patient receives antibiotic treatment for the whole course as they would staying in the hospital with IV. Additionally, patients have less
So one of the key findings that we found is that we were kind of surprised that we were actually doing a really good job with our skin and skin structure patients on the inpatient setting. Our length of stay was actually a little bit less than the national average, and our readmission rates are actually less than the national average as well. So at this meeting, we put together a poster to determine in that patient population, is Oritavancin therapy still advantageous? So would it still be okay for patients or for facilities that are really not experiencing a problem with patients with skin and skin structures staying too long, or maybe utilizing more resources than what would be expected, or maybe having higher readmission rates? And what we found is that we still saw a benefit. If you would actually admit those patients, that the facility was indeed losing money, and they were able to actually make money when we were to send them to the outpatient setting. And from an outcome perspective, we saw that readmission rates were actually much less, even though our readmission rates were already low. When we utilized Orbactive in the outpatient setting, the admission rates at that time were actually less. So we saw both clinical and financial benefit, even in that very non-critically ill population for skin and skin structure.
Issue applied in Ecuador. A follow-up period of 60 days was specified for analysis of safety in the order and evaluate the potential effect in the prolonged half-life of Oritavancin. Safety data were reviewed on external independent data and safety monitoring committee once after 120 patients have been treated again, and after 250 patients have been treated.
Because of our shared mindset, ICPD scientists often see opportunity where others do not. An example of this can be seen in the story behind Oritavancin, a drug that may not be on the market today if it wasn't for the science of PK/PD. Eli Lilly discovered Oritavancin a quarter century ago. And like many long half-life drugs, they tried to develop it as a once-daily regimen. But for some reason, they couldn't get it through phase 3 trials. So in the early 2000s, Oritavancin development was taken over by Intermune, and they too tried to develop it as a once-daily regimen. Not seeing Orivancin potential, they decided to refocus their company and sell it to Targanta. Targanta continued developing it as a once-daily regimen and invited us to work with them. However, after carefully evaluating the PK and PK/PD profiles of Oritavancin, our teams realized that the solution was not to administer it as a series of small daily doses, but rather as one big single dose. Targanta decided to shelve this idea now, but explore it later, after the once-a-day regimen got approved. So they submitted it to the FDA for approval, and after many months, the FDA came back with a rejection. Daily doses of Oritavancin weren't.
Thank you. In conclusion, a single dose of Oritavancin has more effect on twice the element commencing administered for 7 to 10 days for the treatment of acute bacterial skin and skin structure infections caused by gram-positive pathogens. Thank you.